we're going to start with our first panel. Okay, our first panel focuses on behavioral health, an area where the limits of traditional financial ROI are especially clear. Behavioral health programs often produce meaningful benefits, but they may take time to emerge, they may show up outside the health system, or they can be difficult to capture in our standard metrics. As a result, financial analysis alone may not fully reflect the value practitioners see in practice. I'm going to read through our first case study, and then I'll introduce you to our panelists. At any time during the panel discussion, please feel free to submit your questions for the panel through the Q&A feature in Zoom. And we'll have some time at the end of the session to address questions. Okay, so our case study is a national employer, BTF Inc., with approximately 35,000 covered employees, is confronting a rising number of behavioral health insurance claims, persistent access barriers, and avoidable medical utilization among members with substance abuse disorders and co-occurring conditions. In addition, BTF Inc. has noticed a number of issues, including lost productivity, higher rates of absenteeism, increased turnover risk, and member dissatisfaction with network access and care coordination. Feedback from employees has noted that some of the time away from work is related to caregiving for their children related to behavioral health. At the same time, BTF Inc. continues to experience increased overall medical costs and utilization. BTF Inc. is looking for ways to address this multitude of issues. Utilization of available services and outcomes differ across locations, income bands, and shift types. The employer lacks consistent member-reported outcomes or disparity tracking to determine why some seek service and others don't. Now I'd like to introduce you to our panelists, and I invite them to join me on stage as I introduce them. Our first panelist is Mila Kaufman, Executive Director of the DC Health Benefit Exchange Authority. Mila is a nationally recognized expert on the private health insurance market with deep experience in regulation, consumer protections, state and federal reforms, and market oversight. Before joining the DC Exchange, she was a research professor at Georgetown University's Health Policy Institute and previously served as Superintendent of Insurance for the state of Maine. Our next panelist is Deborah Steinberg, Senior Health Policy Attorney at the Legal Action Center. Deb advocates for federal and state policies to improve access to substance use disorder and mental health care. She leads Action Center's work on strengthening mental health and substance use disorder parity in commercial insurance and Medicaid, and on improving coverage of addiction treatment in Medicare. She also serves as an appointed consumer representative of insurance commissioners and is on the board of directors of the Mental Health Liaison Group. Our next panelist is Dr. Rochelle Hendricks Stirrup, Research Director of Real World Evidence at the Duke Margolis Institute for Health Policy. Dr. Hendricks Stirrup leads the Institute's Real World Evidence Collaborative and Policy Research portfolio. Her work sits at the intersection of health policy and innovation and focuses on regulatory, ethical, and implementation challenges in the use of real-world data and evidence. She brings a research, bioethics, and policy practitioner perspective to how evidence is generated and used in decision-making. And finally, Tatiana Kotlovsky, Vice President of Actuarial Services at Optum Health. Tatiana provides actuarial and analytics leadership supporting behavioral health and health services. Her work focuses on forecasting, affordability, and utilization analysis, provider performance, network pricing, and the evaluation of value-based and care management programs. She brings more than 20 years of experience across government programs and commercial markets, and is both a member of the American Academy of Actuaries and associate of the Society of Actuaries. Panelists can please join me on stage. We are grateful to have such a diverse group of panelists with us today, and I'm looking forward to this discussion. So welcome, everyone. I'd like to start with talking about framing of evaluations. So Deb, I'd like to start with your perspective. In this case study, what signals suggest that access challenges may reflect systemic design issues rather than individual choice?
Becky, and thank you so much for having me here today. I'm thrilled to be a part of this event and the opportunity to be on this panel of experts. So I want to start by saying that rising behavioral health claims are not necessarily indicative of systemic design issues. Rising claims in this case are a good thing. Based on SAMHSA's population survey data, we know that only about half of people with mental health conditions receive treatment, and less than 1 in 4 with a substance use disorder do. So, nationally, the claims data show that more people are now getting the behavioral health care they need. So, rising claims is a good thing. But in this case study, seeing a rising number of avoidable medical claims, especially in the emergency department and hospital, are a major signal that there are systemic design issues that are preventing employees and their family members from getting preventative and community based behavioral health care. It means that people are waiting until their conditions become crises. And that means not only that their care will be more expensive at that time, but also that they'll have to take more time off work and need more time to recover. So it's probably obvious to everyone here, but no one likes going to the emergency department for their care. But especially for people with behavioral health conditions, this is not the best setting for their treatment. This is not an individual choice that employees would make. This is a systemic failure. The key signal that this is a design issue is because employees have noted the access issues and dissatisfaction with network access and care coordination. This suggests that enrollees are probably not able to find the in network care they need that would prevent those hospital and emergency visits. This is another data point that we see nationally with incredible research by RTI International and Milliman. People go out of network for behavioral health care far more often than they do for medical or surgical care. 9 times more often for psychiatric visits than for medical surgical specialists, and 20 times more often for subacute facility care like residential treatment. So this is an issue that can and must be addressed through plan design, things like increasing reimbursement rates and building out the network of community-based providers that can offer lower levels of care. And for another, really ensuring that that full continuum of mental health and addiction care is covered in a meaningful way. So those are the systemic design issues that strike me in this case study.
That's really helpful and a good reminder that seeing an increase in behavioral health claims isn't necessarily a problem. So I appreciate you calling that out. Mila, if we can move to you. So I know the DC Health Exchange recently implemented a benefit change for pediatric behavioral health. Can you talk a little bit about this benefit and sort of how you frame the problem that ultimately led to the solution you implemented?
Sure, thank you. First, I'd like to say how appreciative I am of being asked to participate in this panel and for all the work that you, Becky, Annette, through the years, and other members of the Academy have engaged in. This is not easy. If it was easy, we would have solved it by now, right? So thank you for your commitment to the work and asking the difficult questions. So just a little bit first about us. We are the ACA online health insurance marketplace here in the District of Columbia. And we cover about 115,000 people. Most of our enrollees are actually in group coverage. The ones who are covered individually, most are full pay. So most do not qualify for the federal health insurance tax credit that lowers monthly premium. And we were one of 4 state-based marketplaces that opened for business on time back on October 1, 2013. I remember like it happened yesterday. But let me just say that we've been on a journey to figure out how to increase utilization of high value but low cost services, right? Because we want to encourage certain behavior. So we've had standard plan design for years that didn't apply deductibles, for example, for urgent care, but applied deductibles for ER, right? To encourage certain behavior. After COVID, we embarked on a new journey for us. We started to ask the question, and this goes back to your keynote speaker, ask the right questions. So for us, the question was, why are we seeing different outcomes in the commercial population we serve? For us, we don't serve Medicaid folks, so the discussion isn't really about political determinants of health. It's really about most people who are paying full price for commercial coverage. Why are the outcomes different? Why is the value of health insurance to some of our enrollees not as high as to others, right? What contributes to those factors? So, and I can talk, if there's time, I can talk about how we got to where we are. But we changed, the bottom line is one of the things we've done is we've changed our benefit structure. And when we looked at some of these questions, we discovered that post-COVID, we were at high risk of losing an entire generation of Black and Brown children. When we looked at the isolation, the vicarious trauma, and other factors, it became very clear that our problem we needed to solve for was how do we save an entire generation of all children, and especially Black and Brown children who were being impacted in a more dramatic way. So we decided to eliminate almost all cost barriers in the commercial product line that we have for pediatric mental health and behavioral health. And so no deductibles, no co-insurance, and the only copay is $5. And this is for lab work, medication, for pediatrician visits, psychiatrists, psychologists, group therapy, individual therapy, pretty much whatever your kid needs, just $5. And that benefit design went into effect in 2024.
That's excellent. Thank you for sharing that. As an actuary, my natural reaction is, oh, you need, some more cost sharing, is $5 the right amount? And did you get pushback from your actuaries when you were implementing this benefit?
So it was super interesting because we initially implemented zero cost sharing for type 2 diabetes. And so when we started to talk about this benefit for kids, one of our health plans wanted no cost sharing whatsoever. Mm. And other folks in the stakeholder work group wanted a little bit of cost sharing. And so the consensus was $5 was the right amount. When it comes to kids, it takes years for the payoff, right?
Yeah.
I mean, to be that blunt, for us, in even thinking about the problem we were solving for, we need to save a post-COVID generation of children. And how do we do that from the authority we have, from the tools that our health plans have? And so that was the right balance for us.
Yeah, that's great. I think the framing there was really important to that, to how you ultimately came up with the solution. I'd like to move to Dr. Hendrik Stirrup. So we talked a lot today about data, and I really respect your expertise on data. Can you share your perspective on sort of what framing assumptions most often limit the usefulness of data used in facilitating these program evaluations for decision making?
Absolutely. So thank you first and foremost for having me. Thank you for introducing me at the top of the hour, or at least the panel hour. You're right. I think about this a lot from a data perspective. We've already talked a lot about that today, particularly you, Becky, where you mentioned, we can't measure what we don't collect or document. So, there is, an issue where certain populations that don't show up to the health system to receive behavioral health care, substance abuse prevention care, or acute care, when they don't show up, it shows up in our data systems as they don't show up because they don't need it. One could make that assumption. But then when we take a closer look at the data and we look at demographic trends, then we tend to see, well, hold on, there's a certain demographic of people or persons that are missing here, not at random. Is this a signal or cue for us to take as far as action? And so I think about this in two major ways, maybe three actually. One being what I just mentioned, the other being that I think this is probably just a clinical level concern that I have. But right now, behavioral health and substance abuse care, they're treated differently from other areas of care. So, for example, mental illness goes without diagnostic and holistic treatment because behavioral health is perceived differently just from physical health. For some reason, we dissociate the brain from the rest of the body and the behavioral effects of brain malfunction from the rest of the body. And so our system is fragmented along that assumption. I think that first and foremost, from a scientific standpoint, we need to think more critically about that and what it is that we're causing by thinking that way. And then also, the systems that we have are more or less trustworthy. For example, as I mentioned, some people might show up seeking care. They might, receive it. Maybe they don't show up looking for care because they don't know where to go or who to go to ask for or access that level of care. And so again, we're left to, wonder, is it our system not proving itself trustworthy enough for people to go out and seek, this level of care? And what is that doing for us as far as ensuring the wellness of a population as a whole? And so there are a range of ways, I think, in which we can incentivize stronger documentation of these instances. And when they do show up within the health system and therefore in the health record, we have to also say, at least in this behavioral health setting or case, what are other data elements that we should capture in order to ensure that we're caring for this person or this population holistically rather than in one way that is strictly psychiatric? Typically, we see that when it comes to behavioral health care, it's not just a silver bullet, that's just going to cure it all, or there's no cure that we just provide in a pill. It really takes a holistic approach, a community-based approach, whether it's addressing food insecurity, housing insecurity, reestablishing family connection and or support, especially when substance abuse is involved. It really does take an all-in way of thinking in order to address that. And one way we can document this is through the incentivization of Z code, SDOH Z code documentation. So SDOH being social determinant of health. There are certain Z codes that allow clinicians to document within the electronic health record housing insecurity needs, food insecurity, or housing insecurity and or needs, food insecurity, other types of troubles just at home or in the workplace or the community. We have these tools available to us as far as documentation goes. Now, what we don't have robustly are ways to act on that information when it is captured within the health system. And so I know some payers have gone about discussing SDOHZ codes, say like on their websites and so forth. But what's unclear to the public right now is if I do show up to my health system and I express this need and I present them with symptoms that I'm having because these needs are not being met, what are they going to do? Are they going to refer me to ghost networks or a list of referrals that don't exist? Or are they going to actually channel me into my community or into a community that has, all of these systems in place to support me where I am right now, and where I'm limited right now? And so again, thinking about this from a data standpoint, right now we don't have a robust system that allows us to capture data in ways that are incentivized, whether it's the system itself being incentivized directly or whether it's them being incentivized because they know they can support the patient in their next steps. And I think that is certainly something that the actuarial community can think about and innovate around, honestly. And again, I think a lot of what I just said resonates with what a lot of my colleagues today have said as well. So I'm happy to pass the conversation along.
Absolutely. Thank you. And a good reminder on the Z codes. I always forget that those exist myself. And I think it will be great to find ways to collect data and such as that. Tatiana, keeping the momentum on thinking about framing and how we measure success, how would you define success for behavioral health strategy beyond short-term reductions in ED or inpatient use?
Thank you, Becky, and thank you for inviting me. Thank you, Academy. Given how rapidly the behavioral health space is changing and how central it is to become to access and overall health outcomes, forums like this are incredibly important. So I just want to thank you and Academy for creating this forum and give us opportunity. But I also appreciate the question. Thank you. When I think about it, when we talk about success in behavioral health, especially from an actuarial perspective, I kind of want to start by reframing what success actually means. A shift away from emergency department or utilization or inpatient utilization care is an important signal, but on its own, it's not sufficient because reductions in ED or inpatient utilization can indicate progress, yes, but without context, they can also mean something very, very different. They can reflect delayed care, unmet need, access barrier, or disengagement. So the question we ask actuarially, it's not just did utilization go down, but rather did care shift in the right direction? And did the member experience actually improve? So from our lens, again, true success shows up when utilization moves appropriately and engagement increases. So let me explain what it looks like. When we see a shift to lower levels of care, and it's paired with a stronger outpatient or community-based engagement, that's a very positive signal to us. That means that our members are accessing care earlier in the process, and the care is being delivered at the least intensive level, and it's still clinically appropriate. So, but it also tells another story. It's a human story. It means people are not waiting until crisis. They're getting help sooner, and again, in a setting that are less disruptive to their lives, to their jobs, to their families. And again, a reminder, I always try to remind myself, I always talk to my teams about it. Let's remember that every actuarial model actually represents people, and many of whom are seeking care during some of the toughest moments of their lives. So behind every claim is a real person navigating care, very complex care. So it's just a great reminder. And again, ensuring that the member is in the right care is really important. So success is not just about fewer ED visits or lower inpatient utilization. It's members showing up earlier and more consistent. But it's also flip side to all of this. When we see ED or inpatient utilization drop, but there is no corresponding increase in outpatient engagement or lower level of care, that raises concern from us. From actual standpoint, that's actually risky because this pattern may signal that the care is deferred or unmet needs, or it actually, the system becomes unstable because members might be disengaged and because the system might be too complex for them or too hard to navigate. So this is why engagement becomes such a core indicator of success in behavioral health and behavioral care. Another, just a little bit different perspective to this, because I talked about the shift to lower level of care, but sometimes, and while outpatient therapy as a lower level of care, most times are appropriate and effective for a lot of our members, but as for some of the members, when they stay there for a long time without improvement, and we can actually see it as a barrier to recovery. So when we see members struggling, even with a lot of therapy, but worsening the outcome, even with ongoing treatment, it's often a signal for us that the care is not intensive enough. So again, when we put all of this together, what success looks like from actuarial standpoint, it's a shift to lower level of care is a strong signal of success, but when it's paired with sustained member engagement or evidence of improvement. Otherwise, a short-term reduction in ED or inpatient utilization, it can simply reflect delayed care, not better care. And behind every delayed claim is a person who didn't get the help they needed when they needed it.
That's a great perspective. It really brings in that kind of the story behind the claims that you're seeing and how complex it is to even interpret the claims. I think that's a good segue to the next topic, which is a focus on stakeholders. Mila, I'd like to move to you. So the DC exchange, the benefit change that you talked about, explicitly considers children and families, not just the covered individual. Can you talk a little bit about why it's important to consider the children and families when making these benefit decisions?
I'm going to say what all of you know. It's if we were in person, I would say raise your hand if you have a kid. Raise your hand if your colleague has a kid, right? If your kid is sick or you're concerned about your child, your productivity is not the same and you're forced. It's not a choice. You're forced to take time off, right? It is very simple why you want to be thinking about the problem in a holistic way and why there are benefits to payers, to employers for thinking about it in a very holistic way. But if I can also address the stakeholder aspect of your question, for us, it was really important when we embarked on our journey to problem solve that we had different stakeholders at the table. So we had all of our health plans, we had brokers, we had our chambers, we had our customers, employers, we had clinical experts, we had academic experts, we had advocates, patient consumer advocates. And it was really important to get everyone's perspective and level set because it allowed us to embark on this learn together journey to identify and agree on what the problem is that we were solving for, and then use the consensus approach to come up with consensus recommendations, which means 100% of our members on this committee voted to do X, Y, and Z, which is not always easy. And it also brought perspectives that we would have missed in our discussions if people were not at the table. And we learned amazing things that a bunch of our health plans were doing super interesting things, and they never talked about them publicly until we asked, right? And so the journey that you use to solve for however you define the problem is equally important as where you end up. Because unless you get all of that on the table and agreement what the problem is and potential solutions and buy-in, it's going to be really hard to implement any potential solution.
That makes a lot of sense. I find that it's the ideal to get the stakeholder perspectives, but sometimes there's, competing objectives. Tatiana, can you talk a little bit about how actuaries think about those competing stakeholder objectives, especially when you're balancing employer affordability, member experience, clinical appropriateness in one evaluation?
Yeah, thank you, Becky. And this is a question actuaries deal with all the time because these objectives genuinely compete, right? And pretending that they don't is actually undermines credibility. So from an actuarial perspective, the mistake is trying to collapse all affordability, member experience, and the clinical appropriateness into single score or ROI number, right? So instead, we're trying to approach this through a balanced measurement framework where each objective is evaluated side by side. And we show those trade-offs to our leaders, to our stakeholders very clearly. So affordability might answer the question, is this financially sustainable over time? This includes cost, volatility, predictability, and more importantly, it's not just about the cost, whether cost goes up or down, it's whether the spend is aligning more closely with expected need and becomes more stable. Member experience asks something very different. Can members actually access appropriate care, and does the care feel timely, adequate, and coordinated? So improvements there might actually increase the cost, what we heard from my colleagues on the call already, right? but actuarially, that can be expected and even desirable outcome if unmet need is being addressed. So clinical appropriateness focuses on a different aspect of it, whether care is being delivered at the right intensity, in the right settings, at the right time. I talked about it just a few minutes ago, right? This is probably where we see trade-offs most clearly, because clinically appropriate care does not always look like a short-term cost containment. So rather than forcing them into one single number, I think it's important from actual perspective to put them on the same page so leaders can actually see, for example, affordability is under pressure, but experience is improving and a clinical alignment is strengthening. So that transparency is really what's important. And to me, like one of the principles, a model that hides those trade-offs, right, or tensions, it's actually less credible, not more. So this transparent approach, when we talk to our stakeholders, allows organization to be intentional. So when an employer may decide whether the improving access and experience is worth near-term affordability pressure, as long as the path forward is explicit and monitored. On the other hand, they may reset the clinical scope if costs are rising without a clear clinical benefit. So ultimately, the role for actuary in this case study isn't to declare, hey, there is a single winner among competing objectives, is to make sure that we show those trade-offs and those are visible to our stakeholders and quantify if possible and, of course, ensure transparency.
That's great perspective. Deb, I want to keep in mind the member, the consumer at the center of all of this that we're talking about, that there's people behind the claims. How should the experience of those employees who don't access service be considered legitimate evidence when we're talking about these evaluations?
Yeah, this question is so important because, as I mentioned before, less than 1 in 4 people with a substance use disorder receive treatment. And knowing why they don't get treatment can help us improve access for them, saving lives and preventing, emergency medical costs. So there is already generalized data that we have and use that employers could leverage as legitimate evidence in evaluation. So for example, the SAMHSA population survey data that I mentioned before, the National Survey on Drug Use and Health, that asks respondents the main reasons why they did not access treatment. And the most common reasons, the majority say they think they should have been able to handle their alcohol or drug use on their own. They're not ready to start treatment, or they're not ready to cut back on alcohol or drug use. But even with those, a lot of that is still rooted in stigma and misunderstandings around treatment, really to Dr. Hendrik Sturup's point. If we talked about and understood substance use disorders and treatment for them the way we talk about other health conditions like diabetes or cancer, then I don't think you'd be seeing such high rates for these responses. So addressing stigma and discrimination, including through coverage plan design, can help. But there are other reasons that people report not getting the treatment they need that are actually more directly related to plan design and evaluation. So nearly half of people reported thinking that treatment would cost too much as a reason for not receiving care. And at similar response rates, we see that people do not have enough time for treatment. They do not know how or where to get treatment. They are not able to find a program or a healthcare professional they wanted to go to. Or they think they might lose their job or their home or their children if people knew they were in treatment. So these in particular absolutely should be considered in evaluating health coverage, because these indicate changes that can be made, reducing patient costs, expanding networks, making sure supports are readily available, and also improving the culture around these conditions and making sure people know that discrimination is not tolerated. I think sometimes employers are going to be hard pressed to get more micro data than this national survey data, since the fear of stigma and discrimination might prevent people from answering honestly. But at least in this case study, there was survey data like dissatisfaction with the network, as well as the amount of time off that they were spending, caring for loved ones with behavioral health conditions. So to the extent there is more micro or localized survey data that might be available, that should absolutely be considered legitimate evidence in this kind of evaluation as well, especially if we're talking about reducing those unnecessary medical costs and getting people the treatment they need.
That's great context, and thank you for sharing those resources. I think those would be great to use. Dr. Hendrik Stirrup, the Health Equity Committee is often thinking about populations with different needs. Can you talk a little bit about how evaluations can better surface subgroup level variation and/or the combined effects of multiple interventions without sacrificing rigor?
Absolutely. So I do want to call on a study that my team and I conducted, just exploring the literature, looking at, I mentioned already, SDOH Z code documentation patterns. And we found that, at least as far as what's been reported in the literature, among over 2.7 million individuals across 370 plus healthcare encounters, 12 studies only reported the use of SDOH Z codes within the EHR record. And that documentation rate actually ranged very low, between 0.5% to 2.4%. And the documentation often involved patients under age 64 who are publicly insured and who experience, as we know, a range of comorbidities, including depression, bipolar disorder, schizophrenia, chronic pulmonary disease, and substance abuse disorders as well. And we did see also variation across hospital types, number of beds per facility, patient race and ethnicity, geographic region, as well as sex and gender. And so, as we think about the reality of, social needs within these health systems, what that looks like from a subgroup standpoint, and how we should go about looking at trends along these variations, for a specific locality. I don't think that is something that has, effectively been done or incentivized. And again, I think if we can appropriately incentivize our systems to collect, this information on the ground in the community-based settings, then we can, from there identify solutions, again, to deploy resources, better characterize need according to a subgroup. Whether that subgroup would be, along the lines of race and ethnicity. My colleagues have already mentioned that we're at risk of leaving an entire generation of young people behind, especially those belonging to certain groups that have certain vulnerabilities at a subpopulation level. We have to disaggregate the data in ways that allow us to see that. And then we also need to pay attention, again, to the data resources that we have at our fingertips that we can easily, create ideas around as far as incentivization of documentation. I think that's an opportunity that we have right now in order to effectively address the needs of the variety of individuals that show up to our health systems with these specific types of needs and with these specific demographic variables in mind.
Yeah, that's a very low documentation rate, so it definitely looks like room for improvement there. Mila, the DC Policy Exchange really prioritized reducing that out-of-pocket cost, and was the primary benefit you were looking for trying to increase access? Were there other benefits that you considered when sort of designing your solution to this massive problem of trying to protect a whole generation of children?
So the problem of differences in health outcomes depending on your race, ethnicity, gender, orientation, other factors is, we didn't get here overnight. And from our perspective, we were not going to fix it overnight.
Mm-hmm.
So it was, let's fix what we can, knowing it's not going to give us the complete solution that we're looking for, which is same outcomes that are not, influenced by demographic factors. And so benefit design, it wasn't easy. It was very hard, but it was something that we can do.
Mm-hmm.
The one piece we still want to do with our partners is to see whether the changes in benefit design actually resulted in higher utilization of the kind of services we want kids to get, right? And if not, why not? And is it other institutional tools that we all use, but in using them, they have differences in outcomes on the patients, like prior authorization or even case management or utilization management or referrals, like, are we even asking all the questions we need to figure out, are we improving access, getting the utilization we expect to get? So those are all in the future to be looked at as part of this.
Great.
And we'll be looking at a lot more. One other area that is very hard to get our hands around are the clinical guidelines that also contribute to outcomes, right? Even when clinical guidelines have been changed by the clinicians, they're not always adopted in the same way, right? And so even using old guidelines could give you a terrible result depending on your race or other factors. So that's a tougher area for us, but that is something we've also been working on outside of the context of mental and behavioral and substance use disorders area.
Yeah, that's really important as well. Yeah, I'd be curious to see sort of how the program unfolds and what you learn, what you see from this approach. It sounds very promising. Deb, what consumer-centered outcomes are most likely to be overlooked when evaluations focus narrowly just on utilization or cost?
So there's a tremendous report that was developed by Community Catalyst, Face and Voices of Recovery, and the American Society of Addiction Medicine on the outcomes that people with lived experience of substance use disorders actually want in their care. And so they identified 7 key outcomes. So staying alive, improving quality of life, reducing harmful substance use, improving mental health, meeting basic needs, increasing self-confidence and self-efficacy, and increasing connection to services and supports. Now, there were some differences by gender and race and sexual orientation, so that's another important factor to consider for health equity. But unfortunately, most of these are overlooked when evaluations focus narrowly on utilization or costs, particularly because they may be qualitative in nature and they may require addressing social determinants of health, not just the direct healthcare costs. So that's one. Patient or employee time is another key outcome that is also overlooked, or at least I would say undervalued. If you think about network access issues, patient time really adds up. If there's too limited of a network, they may have to travel much further to see a provider, which means they have to miss more work. They may have to call every provider in their directory, which is time consuming and often a little bit futile with the rate of ghost networks. When they exhaust that directory and have to go out of network, many of the out-of-network behavioral health providers do not submit claims directly. So the patient has to upload that documentation and wait to get reimbursed. That's all time away from their job, their families, their lives, and that has value. So saving employee time is another factor to consider. And it's also worth noting that a lot of the nationally recognized quality measures for substance use disorder treatment, at least the ones that would point to some of these more health-centered outcomes, require utilization and cost, but in a good way, right? Substance use disorders are chronic health conditions. So this isn't going to be solved by one emergency department visit or a few counseling visits. The quality metrics we look at are things like how soon the patient had a follow-up after an emergency department or hospital visit, or whether people are receiving medications for opioid use disorder, or whether they're still taking those medications after 6 months. That kind of utilization and those costs are good, and they point to that person staying alive, improving their mental health, being connected to services and supports, and so on. But I would say the most important thing is knowing what people with substance use disorders value and outcomes, because it may not be the same things that you're thinking, and making sure that those values and those perspectives are part of the evaluations, not just the employer perspective or the health system costs.
That's really good perspective. I think the first time I worked with a consumer advocate, they brought up the saying or phrase, nothing about us without us. And that stuck with me, that we really want to take that into account when we're designing any sort of solution or benefit or intervention. So that's a really good reminder. Tatiana, I'd like to move over to a really core actuarial concept, which is credibility, something we talk about all the time. How do actuaries balance credibility with relevance when evaluating these subgroup outcomes?
Another great question, Becky. This is a constant tension for actuaries. On one hand, subgroup outcomes are often most relevant, and they tell us where a program is truly working, where risk is concentrated, and where inequities or access challenges may exist. On the other hand, those same subgroups can be statistically fragile, especially when populations are small or engagement is uneven. So actuarially, our job is to make sure that relevance never comes at the expense of credibility. So what we do, we put guardrails or boundaries around how subgroups results are interpreted. So that includes sample thresholds. Yeah, it's going to get very actuarial right now. Confidence intervals. And importantly, a willingness to interpret results directionally rather than with false precision. I guess one of the guiding principles we use that precision should never exceed credibility. And if the data cannot support a precise estimate, then we should enforce one. So another important aspect is stratification. It plays a key role here. So rather than slicing the data too finely all at once, we start thoughtfully or stratify thoughtfully by dimensions that are clinically meaningful and decision relevant. So what actually our organization or employee tries to accomplish. So such as severity, baseline utilization, access constraints, or care pathways. So the goal is not to create as many subgroups as possible, but to identify a few stratifications that actually explain the difference in outcomes. And so in practice, it often means starting at a very high level. So looking at overall program impact, perhaps, and then using subgroup analysis to answer specific questions like, where is the program most effective? Where is the engagement breaking down? Where does risk remain? So by being clear about confidence and limitations and nuances and assumptions, again, getting very actuarial, we actually preserve trust of our stakeholders, avoiding drawing conclusions where the data, which data cannot support. So in the context of this case study, this means recognizing that subgroup insights are essential for understanding equity, access, effectiveness, and they need to be framed as signals, not necessarily definitive answers when we communicate to stakeholders. Unless the data really truly supports that level or provides that level of confidence. So to summarize, I would say actuaries trying to balance credibility and relevance by using stratification and very thoughtfully, again, being supported by clinically meaningful or appropriate evidence, applying some boundaries about, assuming statistical validity. And so more importantly, resisting the temptation to over precision.
Yeah, no, it's a good balance and it's a challenge in our work. Dr. Hendricks Stirp, that brings us up to a good point, which is something we often face, which is limited data or not having data. How would you approach measurement when member reported outcomes and disparity tracking are limited or completely missing?
Yeah, well, as I mentioned, at the top of my discussion, there are ways in which we can determine whether or not data is not missing at random. Again, when we see missing, data fields, we assume, oh, well, maybe someone didn't document something on accident, the health system's moving fast, maybe we're just, not seeing information simply because it's just, again, a random event that may occur. However, if we're seeing those trends for certain subpopulations more often than others, and if we're seeing that in certain geographies more often than others, then I think, to my colleague's point, that's a signal that is information. No information in that form and fashion is, in fact, information. And I think it's incumbent upon, us and the community and the health system to figure out why that is. And really, it is important for health systems and those that work within it to connect with community-based organizations or even support them, find ways to create them so that they can locally determine in a trustworthy manner what exactly is happening in that community. It's probably the case that the community has an unmet need, but no one is talking to them to figure out why that is, whether it's an unmet need such that there's just a lack of access to care that is, in fact, under demand, or whether there's a refusal of care happening. I think that does require a qualitative approach, which is a bit different than, the quantitative approaches that the actuarial community is used to. However, it really does bring important context around why data can be missing in certain ways or patterns that you see within a data set as you go about plan design and pricing. And so, again, I think it really does, especially in behavioral healthcare settings where, context is everything. It really does take a humanistic approach, and it really does take a community-based collaboration approach to truly understand whether a community is experiencing an unmet need or a refusal, or is in fact engaging in refusal of care.
That's a great perspective. Thank you so much. We do still have a few more questions, but I'd like to invite Susan Pantelli, the Vice Chair of the Academy's Health Practice Council, to join us on stage. She'll share any questions we may have from the audience. While she's joining, I'm going to ask one more question to Deb, if you don't mind, Deb. What common pitfalls in relying on claims data alone to demonstrate parity or adequacy of behavioral health coverage? What are the common pitfalls? Sorry.
Yeah, sorry we have to end on like a really nerdy note. But so first and foremost, claims data will not include people who don't submit claims, which happens a lot for out-of-network treatment. I described before, it's burdensome to submit those claims, especially if the provider won't do it themselves. And often, even with a PPO, you don't get reimbursed all that much. So a lot of people just give up. Others may not submit claims because they're worried what their employer will do if they know that the person has a substance use disorder. So these are pitfalls we have with people who don't submit their claims. Then we have the people who don't receive treatment, but many of them may not be getting treatment because of parity violations, because there are things the plan is doing that make it so they can't find or afford treatment. Low reimbursement rates, coverage exclusions, inadequate networks. And I saw a question in the chat about provider shortages, which are very real. There are mental health provider shortages. But that's not the full story because there are also primary care provider shortages. There are other specialist shortages, and we don't see the same out-of-network usage as we do for behavioral health. So there are system design choices here that may be discriminating against mental health and substance use disorder provider participation. There are other treatment limitations that also may not be apparent through claims data, and I won't go through like the list of NQTLs because that's where I really lose people. But essentially, you won't see the ways that providers have had to adapt how they treat patients because of coverage requirements that violate parity. So this might include when a patient has to fail first at a type of treatment, or when a patient is discharged too early because the peer-to-peer reviewer told the provider during the concurrent review they wouldn't cover additional days. They may be taking a less effective medication because the preferred one is on too high of a tier for the patient to afford the copay. So on face value, those claims look like the treatment is going according to plan, but from the provider or the patient perspective, it might not be the standard of care or the most appropriate care for that person because they knew the right treatment would not be covered. So from the access perspective, which is what parity boils down to, you're not going to see the full picture, the inadequacies, the barriers, or the outcomes that consumers want if you're only looking at claims. It really does require a more comprehensive analysis and evaluation.
Thanks, Deb. Welcome, Susan. Do you have any questions from the audience for us?
I do. First, I'd like to thank the panelists for a great session and all the good work you're doing to move this forward. A question is, how do you incorporate into analysis movement across plans? For example, if a member exits a commercial plan and goes to Medicaid, has the player lost value in giving those behavioral health services? And sort of from the member perspective, is there lost value that they started some treatment that may not be covered any longer?
From the patient perspective, I'll jump in really quickly. I think I would never call it lost value if someone is able to get the treatment that they need. I think the challenge is how you ensure that continuity of care when they switch, because there might actually be setbacks if they've started a course of treatment and have to abruptly cut it off, or if they lose a connection with a provider that they've really built a relationship with. So one of the things that we've pointed to are a lot of the more promising state laws and even some of the Medicare rules that require at least some level of continuity of care so that you're able to at least transition safely to another provider or another medication or type of treatment. But otherwise, it's not lost value if someone's able to start getting treatment they need, and especially if it allows them, again, to participate in work or with their family or in their life.
And I can add, we in DC, we have continuity of care requirements. So there has to be coordination. If someone is moving out of Medicaid into commercial, there is coordination that's required by law. And that works very well for our patient community. The other observation I can share is because we have the entire individual and small group market, and then we also work with Medicaid on Medicaid eligibility. We see some of it, not all of it. We actually see a lot of movement back and forth between group coverage to individual coverage, Medicaid back to group coverage, a lot of it back and forth over time. And so the way I think about value, in addition to what Deb said, value to the patient, right? I think about value to the employer. You may be with the employer for 5 years, you may leave and then come back. So employer community value when you have enough supports that you can actually contribute economically, right? And then system-wide value. We all complain, all of us, about the rising costs of healthcare, right? And so whatever we do, at whatever point in time the intervention is, if it's early enough and there's a lot of value in it, that is part of the solution to the rising healthcare costs, right? So there is value all around, no matter who you look at, to figure out the value question.
Thank you. We did have someone point out in the chat that California has a clear shortage of providers in many areas, and I'm sure it's not the only area. And how do you deal with the lack of behavioral health providers who might serve patients?
I'd like to chime in there. I mean, obviously, you can't force healthcare providers to provide a type of care in a certain place. But I think this also leads us to like a more critical way of thinking about this, to first and foremost say, is it solely a physician's obligation to address behavioral health or substance use care needs in their communities? As we've argued, this takes a holistic approach with more than just a physician perspective or point of view or level of care. And so I think given shortages, can we think of other ways in which individuals' care needs can be met through innovative methods, whether it's a virtual level of care, whether it's medical legal partnerships with anchor institutions that may exist for communities that are remote, that need some sort of connection to resources, whether it's healthcare, whether it's administrative support and navigating a variety of different paperwork that's needed to gain access to social services that might be required, like Medicare and Medicaid level services. A lot of times individuals with mental health care needs, sometimes they're functioning at a high level. Sometimes they are not due to cognitive disabilities or limitations. And so again, thinking about innovative ways in which we can engage the entire range of professionals, entire range of community-based level support systems into these scenarios, I think that will allow us to overcome the challenges that are real with respect to a low number or proportion of behavioral health physicians that, across a range of different geographies.
think that's a great point and a great way to broaden the focus. So thank you for sharing that. I want to thank the panelists for your time today, for sharing your expertise. It's been a great conversation, and I really appreciate you being here.